So we're going to move on and talk about lipids, and I'll try to give you an update on some of the guidelines, some of the controversies. Another area where there's tremendous controversy over the way to approach the patient with dyslipidemia. And here are my financial disclosures. All these slides are on the web. So upon completion of this lecture, I'd like you to be better prepared to recognize the 4 patient populations who benefit most from statin-based therapy according to the ACC AHA guidelines, to define the population where additional lipid-lowering agents with or without a background of statin therapy have further improved cardiovascular outcomes, and to define the role of the PCSK9 inhibitors to further lower LDL cholesterol in the hopes of improving cardiovascular outcomes. I guess we can do this. How confident are you in treating your patients with hypercholesterolemia? From A, not at all confident, to E, very confident. Please answer now. Yeah, I think we can go home. Gosh. I don't know, maybe I can improve, maybe not. Okay, so we're pretty good at this. Now we're getting better. Okay, so there you go. Most common answer, very confident. Okay, very good. So as you know, atherosclerotic cardiovascular disease is the #1 killer in this country. Annual rates, 1.1 million MIs, almost 800,000 strokes. Every 30 seconds there's a death from cardiovascular disease, cardiac catheterizations, percutaneous revascularizations, and surgical revascularizations for an annual cost of over $315 billion a year. Pretty impressive. When you look at the evidence for why statins are the first, as Barry White would say, the first, the last, and my everything, why we're so statin-centric, you can see that the slope of the line in pink for the secondary intervention trials is much greater than in the primary intervention trials in the blue. And when you look at the placebo group, for instance, in the 4S simvastatin trial to the simvastatin group in the 4S trial, you can see that there is a reduction in coronary heart disease events, and there is greater return when there's already established vascular disease, secondary intervention in pink, than when there's primary prevention in blue. Nevertheless, all of these trials suggest that with effective LDL cholesterol reduction, still to be decided what is effective LDL cholesterol reduction, but with that, there is a reduction in coronary heart disease events. And here you can see in a more recent study, when you look at these trials, the secondary intervention trials show the lower the LDL cholesterol, the fewer the events. And this is where we get the target of 70 milligram per deciliter, at least from the trials at the time where we had evidence for reducing coronary heart disease events. When you look at trials that compare high-intensity statin from moderate-intensity statin, and that would be in the PROVE-IT TIMI 2 trial, large trial, looking at 80 milligrams of atorvastatin, double-blindly randomized, compared to pravastatin 40, and you see that there's a greater reduction in LDL cholesterol, 49% versus 21% with prava, and you can see that this corresponds to a median LDL reduction of 95 prava 40 versus 62 with atorva 80, that there is a further significant p.001 reduction in vascular events with the high-intensity statin, atorva 80, versus the moderate-intensity statin, prava. But of important note in this sub-study by Wiviot in the JACC 2005, there is no floor of LDL benefit, and as opposed to blood pressure, where we do know that there is a U-shaped relation or J-shaped relationship, that is, there is a blood pressure where you now have decreased renal plasma flow, increases of creatinine, where you can no longer lower blood pressure. That is not true with LDL cholesterol reduction. And currently, we do not know how low you can go, but there doesn't appear to be any danger in going lower. And this trial shows that in retrospect, an LDL less than 40 showed a 39% reduction in event rates, 40 to 60, 33%, 60 to 80 at 20%, and the reference was an LDL of 80 to 100. So there is no floor. We don't know what the best LDL is, but there's no harm in going lower. Now, currently, you can see that for every millimole per liter reduction in LDL cholesterol, which is about 39 milligram per deciliter if you practice in this country as opposed to Canada or in Europe, that there's a tremendous benefit. And the benefit is all about risk. The greater the risk, the greater the benefit. The lower the risk, the lower the benefit. The reason we will not put statins in the waters of our cities is because as a primary prevention strategy, these drugs do increase glucose, do increase new onset diabetes, and although they really don't need all that much monitoring, that is to say, we no longer recommend serially following liver function tests or even getting a CPK unless the patient is symptomatic, the FDA believes that a clinician needs to prescribe these drugs, not over the counter, and we need to monitor patients for any untoward effects or beneficial effects that occur. Nevertheless, from this cholesterol treatment trialist review, for every 40 milligram approximately reduction in LDL cholesterol, there's a tremendous benefit in any major coronary event, coronary revasc, any stroke, or any major vascular event. And this summarizes from an earlier study in a large patient group the benefit of about a millimole reduction in LDL cholesterol. 23% reduction in major cardiovascular events, 20% reduction in coronary heart disease death, 22% reduction in ischemic strokes. Benefit entirely in proportion to the LDL reduction. The LDL hypothesis is alive and well. No influence of baseline LDL on level of benefit. It's all about risk, but regardless of your LDL at baseline, if you're at high risk, you benefit. No effects on gender, age, or other risk factors. Similar relative risk reduction in all subgroups, and no increase in non-cardiovascular mortality. So there's tremendous evidence for the benefit of statins, and the controversy arose in 2013, the end of 2013, when the American College of Cardiology, American Heart Association guidelines came out. And in this guideline, which like the 8th report of that JNC group, this report tried to be evidence-based, only looking at double-blind randomized clinical trials, well-constructed, and what the evidence from those trials suggested to us. When you look at the threshold for LDL cholesterol reduction from 1988, from the adult treatment panel 1 on the far left, where the goal was less than 130, to the goal that all of you remember went down to less than 100, and the most recent goal in the 2004, prior to the 2013 ACC guideline, the 2004 therapeutic update, which was an addition to the ATP 3 goal in 2001, where they suggested that you had the option of going to less than 70, and this, of course, stuck for the 2006 and 2010 American Diabetes Association. So that has been, if you're goal-oriented, less than 70 in the highest risk individuals, those with an acute coronary syndrome. This has been the goal that people have been striving for and targeting. But in 2013, the American College of Cardiology threw us a curveball when they said they had a new perspective on using LDL cholesterol as a target, or non-HDL cholesterol. And by the way, non-HDL cholesterol, which is the total minus HDL, which can be obtained on a non-fasting specimen at 3 o'clock in the afternoon on Mr. Jones, who has an afternoon appointment. Just take the total cholesterol and subtract the HDL. This is the best prognosticator for your risk for atherosclerotic vascular disease. And in general, it's about 30 more than your LDL target. So if your LDL target's less than 70, the non-HDL is less than 100. But they said there's no randomized clinical trial evidence to support continued use of specific LDL cholesterol and or non-HDL treatment targets. What they said was, based on the clinical trials, the appropriate intensity of statin, like that TIMI study I showed you, where you either used a high-intensity statin like atorva 80 or a moderate-intensity statin like Prava 40. It was the appropriate intensity of the statin therapy, as used in the clinical trials, that should be used to reduce ASCVD risk in those most likely to benefit. So in a sense, they said, understand the patient's risk, use the statin that is most appropriate for that risk, and get them to tolerate that statin, and you'll have improved outcomes. But do not chase an LDL cholesterol, because none of these trials actually double-blindly randomized patients to different targeted LDLs, nor did they follow up and chase an LDL target. So it wasn't evidence-based. Furthermore, the curveball continued when they said that non-statin therapies, whether used alone or in addition to statins, do not provide acceptable ASCVD risk reduction benefits compared to their potential for adverse effects in the routine prevention of ASCVD. Now, that statement actually is not quite correct, and I'll show you that in the patient that doesn't tolerate a statin, the use of gemfibrozole, the use of niacin, nicotinic acid, the use of bile acid resins are beneficial for reducing events, although clearly statins have the greatest evidence of benefit and improvement. So when you summarize these targets, total therapeutic lifestyle change is still recommended in the 2013, almost 2014 guideline. It's an integral part of risk management. LDL cholesterol is no longer a primary target, according to them, of lipid-modifying therapy. Non-HDL is no longer a secondary target. HDL, there's no goals, there never have been, and there's no evidence, actually, that modifying HDL by drug therapy improves outcome. So for the clinicians in our group that have an HDL of 22, that want to go into that supply closet and take a little nicotinic acid to boost their HDL, or a little gemfibrozole or fenofibrate to raise their HDL, there's no evidence that quantifyingly increasing HDL by drug therapy improves outcome. And then finally, for triglycerides, they said there are no treatment goals identified in any clinical trial for triglycerides, and the risk of pancreatitis at a triglyceride of greater than 500 is much greater than the risk of ASCVD, which really does not increase until the triglycerides are much higher. So a little bit of a curveball at the end of 2013. And why did they say that? Well, after a comprehensive review, no randomized clinical trials were identified that titrated drug therapy to specific LDL cholesterol or non-HDL cholesterol goals to improve ASCVD risk outcomes. However, the randomized clinical trial evidence clearly shows that ASCVD events are reduced by using the maximum tolerated statin intensity in those groups shown to benefit in those trials. In addition, there was no additional ASCVD event reduction from the addition of non-statin therapy, that is, adding gemfibrozole or fenofibrate, I should say, to a statin, where you wouldn't add gemfibrozole, only use gemfibrozole when it's monotherapy. But when added to a statin for the glucuronidation and risk of rhabdo, clearly fenofibrate should be used. There's no evidence in any trial that adding fenofibrate to a statin improves outcome, and 2 trials did not show that adding nicotinic acid to a statin improves outcome. Both the AIM-HI and the Accord lipid arm did not show benefit. So this was quite a surprise to many of us in the audience. That is to say that percent LDL cholesterol reduction was the way to go, and there was no target on the left-hand part of the slide from the ACC AHA or the ADA. If they need a lot of LDL reduction based on their risk, use atorva 80, use Rasuva 20, perhaps use Rasuva 40. But those are the high-intensity statins, as I'll show you in a couple of minutes. On the other hand, controversy exists, because on the right-hand side of this slide, the National Lipid Association, the American Association of Clinical Endocrinologists, the International Atherosclerosis Society, and the European Society of Cardiology and Atherosclerosis still recommend an LDL target. Furthermore, for the ACC AHA, it wasn't that they said you couldn't use an LDL target. They just said there's no evidence to use an LDL target. So by a show of hands, how many of you still target LDL cholesterol as opposed to how many of you just target the intensity of the statin chosen? How many of you don't use, how many of you are not answering? How many of you don't treat people with dyslipidemia? Okay. It's a shy group?
What about LDL-P?
LDL particle?
Yes.
Oh, let's get that in the question and answer period. Yeah, we'll go through that, please. Great question. So, when you consider the statins in combination, there's no evidence to use niacin with a statin. There's no evidence to use fenofibrate with a statin. There's no evidence to use fish oil with a statin. They're indicated for hypertriglyceridemia, at least not yet. Now, ezetimibe, I'm going to show you the trial, the Improve It trial, but if you're following the web very closely, the FDA group that just assessed ezetimibe for a new FDA indication did not recommend it. We'll talk about that. And bile acid resins, although there is evidence as monotherapy, there's no evidence that adding a bile acid resin to a statin further improves outcome. So we're a little limited if you're evidence-based and only use the evidence. Now, the American Diabetes Association, like the ACC AHA, said it's the intensity. They recommended the statin dose in that column as, depending on your age, either none if you're less than 40, because no clinical trial enrolled people less than 40, but we're practical. If you have a high-risk person, 35, would you deny them a statin just because they weren't 40 years of age and older and couldn't be included in a clinical trial? Well, we're usually more practical than that, but individualized, and we gain the patient's trust and buy-in, and we might use a statin, certainly. But they said that depending on their risk, cardiovascular risk factors or overt cardiovascular disease, it was the intensity of the statin and not an LDL target that should be targeted. So that's a very interesting agreement with the ACC AHA. On the other hand, here's the National Lipid Association that came out after the ACC AHA, and they, depending on the risk or the criteria, depending on the risk factors, they have targets. And you can see the targets in this slide. And for very high, they have the lowest target as less than 70. And that's what many have been doing, and many continue to do, even though there may not be clinical trial evidence of that. The reality is, when you look at the National Health and Nutrition Examination Survey, we don't meet targets. And it'll be interesting to see in the future if the bean counters, the people that evaluate our, quote, performance, the people that may be willing to pay for performance, will target a particular LDL cholesterol target, or will just say, Dr. Basil, you're using atorvastatin 80. It's a high-intensity statin in this patient that needs high-intensity statin. They're refilling their prescription. You're doing all you can. We don't even care if you check an LDL. On the other hand, perhaps other evaluators will say, no, we still want you to meet an LDL target, and that's how we will evaluate. So this is a moving target, if you will, an unresolved issue in lipid control, and something that we haven't done well with here. 72% did not get less than 70, and in this NHANES data from 2007-2008, less than 24%, or only 24% got less than 100. So it's interesting. Now, when you look at the bile acid resins going back many, many years, 1984, as monotherapy, the bile acid resins compared to placebo reduce LDL, and they reduce vascular events. And gemfibrozole in the Helsinki Heart Study also, as both a primary and a secondary intervention with no underlying atherosclerotic disease or secondary intervention, also, compared to placebo, reduce vascular disease. But there's no evidence that these drugs on top of a statin have been shown to further benefit outcome. So if you're evidence-based, would you add them to a statin? Perhaps you would. Perhaps you would add a bile acid resin, which is generic and inexpensive, as opposed to using ezetimibe, which has some evidence, I'll show you in a minute, but is a trade name product. When you look at niacin as a monotherapy before statins, 1975, 1988, remember lovastatin came out in 85, not much penetration. And these two trials showed a reduction in mortality with nicotinic acid, with niacin, up to 3 grams a day in the Coronary Drug Project, and a benefit in the Stockholm Swedish study in underlying ischemic heart disease, but there was no penetration of statin use. Would you use niacin on top of a statin when both the AIM-HIGH trial and the ACCORD lipid arm showed no benefit? So with gemfibrozole, both the Helsinki Heart Study and the VA HIT, primary and secondary intervention showed a benefit. There was less cardiovascular event rates when you use these drugs, but there was almost no penetration of statin use. And the same in the other studies in the bottom. There was no benefit in those where a statin was the background of therapy. So perhaps what happens is the statins reduce LDL so much, with or without the other pleiotropic effects that they create, the benefit, that the incremental benefit of adding one of these other drugs on top of a statin is so small we're not able to show a benefit. These are the issues. So let's go through this guideline. This is the one that I told you no longer uses the LDL targets and uses the intensity of statin. They identified 4 statin benefit groups. These were people with clinical ASCVD, secondary prevention, the people that we should have statins in the waters of our fountains for, if we could identify everyone that has underlying vascular disease, cerebrovascular, cardiovascular, peripheral vascular, and ask them to please go to that water fountain because we're going to give them the right statin, and they should take it every day, and we will monitor them. We'll take a history from them. We'll see if they have any untoward effects. We'll see if they need any follow-up lab tests. The second group would be those with an LDL 190 or greater. These are people on the bell-shaped curve that are way out of the bell-shaped curve. As Yogi Bear used to say, these are not your average bear. So when you see people in your practice with an LDL this high, you've got to think of a familial hypercholesterolemic. If they're adolescents with a very strong family history, they could have the homozygote double whammy, but more likely in an adult practice, they're going to have familial heterozygote hypercholesterolemia. And I'll talk about that in a minute. That's the second group. The third group are the diabetics. And because of the ages that were included in the studies, these were 40 to 75-year-old people. Would you exclude a 38-year-old? Would you not include a 77-year-old? These are issues. But they had an LDL to get into the trial between 70 and 189. And in this group, as well as when they're not a diabetic, but they have a risk equation calculation of a 10-year risk of 7.5% or greater, they're recommended for statin-based therapy, compared to if their risk is 5 to 7.4%, not high intensity, but moderate intensity. These are the 4 groups. I will bring this home in a future slide, but these are the 4 groups that are recommended. So let's go through this. You're an adult, 20 years of age and older. Are you a candidate for a statin? Well, if you have clinical ASCVD and you're less than 75 years of age, no greater than 75, they recommend level of evidence A high-intensity statin. Now, if you're older than 75, because older people have difficulty tolerating high-intensity statin, they say you could start with a moderate-intensity statin. So that would be a Torva 10, okay? That would be Simvastatin 40, but not Rosuvastatin or Atorvastatin. You're not that group. What about an LDL greater than or equal to 190, where the possibility of a genetic heterozygote or homozygote hypercholesterolemia exists? Well, in this, we use a high-intensity statin, and if not, a moderate-intensity statin. Well, you're not in that group. Are you a diabetic, type 1 or type 2, age 40 to 75, with an LDL of 70 to 189? Here, depending on your risk, this is one of the 2 populations where you use the risk calculator. You're going to use a moderate, lower risk, or high-intensity statin, higher risk. And then finally, you're not in that group. So you're just an everyday Joe walking around, depending on your age, which is very age-sensitive, you have a 10-year atherosclerotic vascular risk. And if you're between 40 and 75, you're going to be on a moderate to high-intensity statin based on the risk calculation. So there are 2 groups that get a risk calculation. Both do not have underlying atherosclerotic vascular disease, and 2 groups where you don't need a calculator because you know they already have atherosclerotic disease, highest risk, they should all be on a statin, level of evidence A, top group on here, or they may have a familial hypercholesterolemia. On the other hand, many in this audience have no disease, have a favorable LDL or a low risk, and here they're asked to have their lipids rechecked every 5 years and to recalculate their risk every 5 years. And that's how you follow them up. This is a very, very important slide just in clinical practice if you'd like to remember who's identified and what you use. Now, to get the risk calculator on your iPhone, all you have to do is just put in the app, look up the app for the AHA CV Risk Calculator. It's a free download. And what it does is it tells you several risk factors on the far left. Your gender, your age, your race, your total cholesterol, your HDL, your systolic blood pressure, are you being treated for high blood pressure, are you a diabetic, and are you a smoker? And it asks those questions, and it just plugs in, you plug in the answer. And you can do this on your desktop, you can do this on your iPhone, and it tells you the 10-year ASCVD risk. In this patient, it was 7.7%, greater than or equal to 7.5%, but not 5 to 7.4% or less. And it compares you to the 10-year ASCVD risk for someone your age with the best answers for all of those 7 risk factors. And what I want to tell you is that it's extremely sensitive to age. It'll be an unusual man, 65 years of age and older, woman, 65 years of age and older, or male, 55 years of age and older, who will not meet the risk calculation for high risk. So that's a problem with the risk calculator. Age drives the risk. So you can be a virgin in terms of everything and be 68 years of age and be recommended for a statin. And that's an individual decision that you can decide. Perhaps you believe that and you would like to offer that to your patient. Individualization, patients trust you, that's why they go to you, and if you gain their confidence, you can get them to take it because you believe it will help them. Another clinician might not feel that way. And that's why there's no absolutes here. There's no absolutes here. Now, let's talk about the intensity of statin. 3 columns. On the far left is atorvastatin 80. That's a high-intensity statin. It's going to give you more than 50% LDL reduction. If your patient's at very high risk and you believe you need more than 50% LDL reduction, put them on atorva. You may or may not check their LDL cholesterol after they take the statin. I personally believe you should, because there's individual variability in the patient's response. And you won't know that until you check the LDL cholesterol. But once you check it and see what it's at, I'm not sure you need to serially follow it or spend any more money on serial lipid follow-up. Perhaps you think you should. Rosuvastatin is hard to get people to take 40. It's still a trade name product, but 20 has been looked at in the Jupiter trial for primary prevention. So these are the 2 high-intensity statins. Atorva is a generic drug. On the other hand, there are many moderate intensity statins, and the single asterisk means they've been looked at in a clinical trial, that drug, that dose. So you can see, you can feel very comfortable with simvastatin 40. It's been looked at in a number of trials. It's extremely well priced. If they don't tolerate atorva or don't need atorva, you can go to Simva. But remember, you can't use 80 as Simva unless they've been on it for a year, because the FDA has told us that they're concerned about the interaction of higher dose Simva. Okay, so low-intensity statins. Dr. Urban, I know, loves pravastatin in an HIV population because they're not metabolized by the P453A4 system, and they're through the 2CD9, and it's great, but they're not very potent. So if you can get someone on Prava 40, you can do pretty well. Prava 80 is a little tough sometimes, but you can do okay there. But 10 and 20 of Prava, you're not going to get much LDL reduction, less than 30%. So greater than 50% high intensity, 30 to 49% moderate intensity, and on the far right of the slide, less than 30% intensity, depending on how much LDL cholesterol reduction you need from baseline. This is the individual variability. It's a great study in atherosclerosis, and it shows for a variety of different patients, 10 milligrams of atorvastatin gives you a variety of different LDL reduction. So there's individual variability in the LDL reduction that you'll see with the same drug at the same dose. And you should remember that. Statin intolerance. The FDA does not like this term because they believe it's our ineffectiveness of playing statin roulette with patients that doesn't allow us to get them on a statin. It's sort of like we kind of give up, but I know many of you don't do that. And so you pick a statin at a dose, and the patient comes back unable to tolerate it. Of course, they've read the product insert, and they have everything that's in the product insert. So you use a lower dose, and they come back. And once they have symptoms of muscle aches or muscle pain, aches much more common, that's when you get a CPK. You do not have to get a CPK at baseline. You should get LFTs. But on follow-up, you never have to repeat an LFT for the whole life of their being on a statin, unless clinically you think it's affecting their liver function. So they get yellow, they get anorexic, they get nauseated, they are weak. Whatever is your clinical barometer for liver disease, that's when you'd get liver function tests. But all those years we were chasing LFTs, we could have saved a lot of money according to the FDA. And let me just tell you that it's not uncommon for people with dyslipidemia to have fatty liver or NASH, non-alcoholic steatohepatitis, and they have less than 3-fold elevation in liver function tests. And statins, you'll learn from Dr. Sanyal, are actually the treatment for NASH. So you don't have to stop the statin because they have Mickey Mouse elevations of the LFTs. However, you've ruled out viral hepatitis, other causes of the hepatitides. So a lot of people have non-alcoholic steatohepatitis, and they'll actually do better on the statin. So we don't chase the statins, and we try to use a lower dose of the statin. We might use it every third day, every second day, once a week. We just want them on some dose of statin, realizing they'll have less LDL reduction if they have to take Rasuva 10 once a week. It's about 17%. If they took Rasuva 10 every day, they'd probably get about 48 to 53% reduction in LDL cholesterol. So statin intolerance is most commonly muscle pain, aching, and weakness, commonly leads to them stopping the drug. Intolerance may be the result of the perception or expectation by clipping the package insert on the treatment. Most statin intolerant patients can be successfully rechallenged, and they're not intolerant until they have been rechallenged at least once. When you look at the double-blind randomized statin trials, 5% don't tolerate the statin. And the difference between those that don't take the statin and those that do, in the double-blind randomized, about 1%, 5 to 6%. A subset of patients, and it's probably less than you believe or think, a subset of patients are truly statin intolerant, but it's much smaller than we believe. And the FDA defines statin intolerance, and this is important for the PCSK9 inhibitors, as patients who have either been optimized on a statin or are unable to tolerate any statin type or dose. Okay? So they will not allow the term statin intolerance to be included in the labeling of the PCSK9 inhibitors. But they consider a patient statin intolerant when they're on the highest dose of statin they'll tolerate, or they're just not able to tolerate it. Okay. That's the statins. We are very statin-centric. We have tremendous benefit and evidence of benefit from the statins. In the only trial that has shown an incremental benefit on top of a statin, the Improve It trial, these were in patients that had an acute coronary syndrome, either unstable angina or a non-STEMI or a STEMI MI within the past 10 days. And within those 10 days, they were double-blindly randomized to simvastatin fixed dose 40 in blue or simvastatin ezetimibe 40-10. And you know that as Vytorin. This was an industry-sponsored trial by the makers of Vytorin, but it was very well conducted over 7 years. And the follow-up visit was about every 4 months, and the trial was stopped early, and the minimum follow-up was about 2.5 years. And the primary endpoint was a composite of cardiovascular death, MI, hospital admission for unstable angina, coronary revascularization, or stroke. Here were the LDL changes. Simva 40, LDL was about 70, 69.5, but when you added ezetimibe 10 to the same Simva 40, it was 54. A 16 milligram per deciliter difference between Simva 40 or the combination, which translated into a statistically significant 0.016 benefit on the primary endpoint. So this trial met its primary endpoint, and you needed to treat 50 patients for 7 years to show this incremental benefit. 10 of ezetimibe or Zetia on top of simvastatin Zocor 40 compared to Zocor 40 alone. When you place this trial on the LDL hypothesis line, it fits perfectly. For the amount of LDL that occurred, it showed the benefit that was expected. And all of these trials fit on this LDL hypothesis line. So if anything, it clearly further substantiated the LDL hypothesis. With a 16 milligram further reduction, there was further benefit. What's interesting about the trial is that when you look at the adverse events, which were adverse events leading to discontinuation, AST or ALT elevation more than 3 times upper limit of normal, myalgia, rhabdo, memory impairment, hemorrhagic stroke, there was no correlation between the final LDL cholesterol and any of these side effects. So as I said earlier, in this trial, there's no harm with further LDL reduction. There seems to be no floor for adverse events. How low to go is unclear. So this trial reaffirmed the LDL hypothesis. Lower LDL was better. It also reduced high sensitivity CRP above and beyond the statin, which ezetimibe is known to do. And 7-year follow-up, they did better. Safety endpoints for cancer, there was no more cancer on the combination. Myopathy, liver side effects, there were no more. So it was safe and it was effective. And yet, the FDA advisory panel 2 days ago voted against the changing of the package insert of Vytorin compared to statin by itself for this benefit in atherosclerotic cardiovascular disease. They said that although it was a statistical benefit, they felt the clinical benefit, the absolute benefit, was extremely small. We'll see what the FDA does on it. But this is the only trial on top of a statin, if you're evidence-based, to show there is an incremental benefit. I don't have time to go into it, but I will tell you that 5 milligrams of ezetimibe does almost as much, about a 16.7% LDL reduction, as 10 milligrams. So although it's not FDA approved at 5 milligrams, if you were to break the ezetimibe as a cost-conscious measure, you'll get almost as much LDL cholesterol, okay? So just know that as well. Okay, so the addition of non-statin cholesterol-lowering drugs may be considered if the ASCVD risk reduction benefits outweigh the potential for adverse effects. And this is also from the ACC AHA guideline. So here's a case, 51-year-old male, at age 41 was treated with a PCI for an LAD occlusion, had angina. At age 49, further developed coronary disease and now had a CABG. Hasn't smoked in 20 years, drinks a couple of beers on the weekend, not a diabetic, no hypertension, no thyroid or liver disease. When you look at the family history, the brother died of an MI at age 43, sister had angioplasty at age 52. So this is not your average bear, Yogi. Currently on atorvastatin 80 and ezetimibe 10, did not tolerate a bile acid sequestrant or niacin, and they are the lipids. So on treatment, this patient has an LDL much higher than 190, and the LP(a) of interest is high. Not obese, good blood pressure, has corneal arcus and tendinous xanthomata on the Achilles on examination. So this is a patient that fits that second group for a familial hypercholesterolemia. Strong family history, personal tendinous xanthomata on measurement, do not need genetic analysis. This patient has heterozygote hypercholesterolemia and is a candidate for a statin. Now, heterozygote familial hypercholesterolemia is found in about 1 in 300 adult Americans. It is more common, 5 times more common than cystic fibrosis. It is 4 times more common than sickle cell disease. We need to think about this, and we think about it just based on the patient's presentation of an LDL cholesterol. In addition, the family history is extremely important. If the pediatricians have not identified these people as young people because they have a heterozygote hypercholesterolemia, we need to identify them as older adults. When we identify ASCVD, it's not only their heart. It's either coronary heart disease, cerebrovascular disease, or peripheral arterial disease. And all of those are ASCVD. On the other hand, how do we identify familial hypercholesterolemia? Well, they come in two varieties, heterozygote hypercholesterolemia or homozygote hypercholesterolemia. And these are either a defect in the LDL receptor, in the ApoB, lipoprotein, or in the PCSK9. And either they get the double whammy or the single whammy, depending on when they present. If both parents are contributing to their condition, they present as young adults. If one parent is contributing, they present as older adults. But the highlight is the intensity of the LDL cholesterol elevation and the associated findings, be it family history or personal history of the xanthomata, of the xanthelasma, okay? And basically, that's what defines this condition. So this is one of the 4 groups that's targeted for statin-based therapy. It's inheritable almost always as an autosomal dominant disorder. Familial hypercholesterolemia is due to mutations that result in decreased clearance of LDL particles from the plasma. Usually it's a loss of function in the LDL receptor gene. You don't have as much LDL receptors, you can't clear LDL cholesterol, it's deposited in the vasculature, premature atherosclerotic disease. Other mutations include the ApoB and the gain of function in the PCSK9 gene, and that'll make more sense in a minute. The clinical manifestations include severe LDL excess, often accompanied by cholesterol deposition in tendons and xanthomas and in the eyes, and evidence of premature atherosclerotic cardiovascular disease. In this country, we do not recommend genetic analysis. And many insurance companies won't pay for it because we use a clinical criteria called the Simon-Broom criteria. In Europe, they pay for genetic analysis. This gets us to the PCSK9 inhibitors. These are proprotein convertase subtilescin kexin 9. They are a serine protease, which is a scavenger protein, which does nothing more than chaperones another protein. It's a protein secreted by the liver, which acts as a chaperone for the LDL receptor, targeting the receptor for degradation. The more PCSK9 you have, the more LDL degradation occurs, and the more LDL that can deposit in the vasculature. Patients with gain-of-function mutations in PCSK9 have fewer LDL receptors, and they have premature atherosclerosis. But groups that have loss-of-function mutations have less LDL and less atherosclerotic disease. So what did these scientists do? They developed a subcutaneous monoclonal antibody against this normal receptor to bind the receptor so that it cannot get on the apolipoprotein B and take the LDL receptor into the liver for degradation. Thus, there's more LDL receptors available for processing LDL cholesterol. Here's how it works in all of us. In the dark brown is our intravascular space. The light brown is our liver. And in the liver, we produce LDL receptors, and we also secrete this chaperone protein called PCSK9. The LDL receptor normally binds to the apolipoprotein B component of the LDL particle. There it meets the PCSK9 chaperone. When it does, these 3 particles come into the liver, and through endocytosis in the lysosome, the LDL receptor is degraded with the LDL cholesterol. And instead of having a normal recirculatory pathway of about 150 times in each LDL receptor's lifespan, it's lost. The more PCSK9 you have, the fewer LDL receptors, the higher your LDL cholesterol, the more atherosclerotic disease you have. So, if we could develop in yellow a monoclonal antibody to the PCSK9, we could bind it, not allow it to get on that apolipoprotein, where it allows LDL cholesterol to be metabolized and degraded, but the LDL receptor keeps going back into the intravascular space. And this is exactly what happens when you give a subcutaneous injection of PCSK9. Now, you ask yourself, perhaps, why would the good Lord give us PCSK9? And some people believe that when we were primitive and meat lovers and were unable to, and when we were nutritionally depleted, this would enable us to have higher cholesterol for nutrition, although we paid a price for it. Other than that, nobody has come up with a reason of why we have this natural serine protease protein secreted by the liver and put into our intravascular space, but that is what it is. This was discovered in 2003 by the group at the Dallas Heart Study, who noted that there were two populations of patients that had extremely low LDL cholesterols and extremely high LDL cholesterols. And when they looked at them, they found, especially in these African Americans, that there was a group that had mutations to the PCSK9 receptor. And so they did not produce PCSK9, and by doing so, they shifted their LDL cholesterol far to the left, and they had much less atherosclerotic disease. So they said to themselves, well, could we make an antibody to this natural protein and create an environment where we would lessen the burden of atherosclerotic disease by lowering the LDL cholesterol? So there are at least 10 of these in development. You know 2 of them that are now FDA approved. And they are ocumabs because they are truly human monoclonal antibodies. Now, the Pfizer bosacizumab is close to FDA approved, but notice it has a Z in it because it's humanized monoclonal antibody, not full monoclonal antibody, which is made from the mouse protein in all of them. These are very well-studied proteins, very well-studied drugs, and their outcome trials are still ongoing. So we know they can knock the hell out of LDL cholesterol and reduce it, but can they improve outcome? That's what we don't know. And that's what the FDA, quite honestly, is still looking for. But we know that it can lower LDL cholesterol, and in some of the patients in the trials, to nothing. What would you do if a patient came back with an LDL cholesterol of 0? And they feel well? And you don't know the natural history of this. Well, as I told you earlier, currently we do not believe that there is any floor for LDL reduction. We don't know if you have to do it that low, but in the trials they did not back off on the drug, and they found no more adverse effects over the life of the trial. So these have been extremely well looked at in atherosclerotic cardiovascular disease and in heterozygotes and homozygotes. And I'll contrast them in a minute. But on top of statin-based therapy, they further lower LDL 50 to 60%. They result in LDL cholesterol level reductions of 40 to 70%, triglyceride and Lp(a) reductions of 30%, on or off the statin, with or without familial hypercholesterolemia, with or without clinical ASCVD. There are 2 FDA indications. There are no dose-limiting toxicities that have been seen except for injection site reactions, about 5%, and to date over 10,000 patients have received these drugs. They're recommended by the FDA as an adjunct to diet and maximally tolerated statin therapy. Remember, that's any dose of a statin or inability to tolerate the statin, but that's how the FDA defines it. Maximally tolerated statin therapy in adults with either clinical ASCVD, heterozygote familial hypercholesterolemia, and evolocumab is also indicated in people 13 to 17 years of age. The other drug, alirocumab, is only adults 18 and over because it has an indication and has been studied in the double whammy or familial homozygote hypercholesterolemia. LDL apheresis used to take the place of perhaps where this drug will now be used, because LDL apheresis every 2 weeks at a medical center will remove LDL like hemodialysis removes proteinaceous waste that the kidney cannot rid the blood from. So LDL apheresis is still alive until we decide who will pay for these drugs. Very quickly, there are 2 on the market, and here's how they are different. When they were approved, no big difference. what they are FDA approved for, both for clinical ASCVD, both for heterozygote hypercholesterolemia, only evolocumab for homozygote. They have different doses. It's either every 2 weeks or once a month. Alirocumab, you start at 75 every 2 weeks, and you can go up to 150. And they recommend you measure the LDL in 4 to 8 weeks to decide if you need 150. Evolocumab is 140 every 2 weeks, and they don't say you should get the LDL cholesterol. You can just continue, or if you want, you can give 3 injections of 140, which is 420 every month. They only say you should measure the LDL cholesterol in the product insert if you're treating homozygote hypercholesterolemia, because there you don't know how many LDL receptors the patient has, so you don't know how effective the drug will be on the LDL cholesterol. And the storage life is a little different between the two drugs. The big issue is who's going to pay for these drugs. They're about $14,000 a year, and as opposed to the hepatitis C drugs that are curative, these drugs have to be given, as far as we know, lifetime. And who's going to pay for them? So until we have the outcomes, there's a little hemming and hawing about it. But here are the patients you should consider for this type of drug. A 60-year-old white male who's had an MI 6 years ago, had a stent 6 months ago. He's on a Torva 80, and here's his LDL. You could add ezetimibe. You could consider a PCSK9 inhibitor. You could just follow them. That's a choice, individualization. On the other hand, here's a 40-year-old white woman who had a baseline LDL of 220. She's one of the 4 groups. She's Yogi Bear outside the bell-shaped curve. She's on Rasuva for 7 years, and her LDL is 156. Her father had an MI at 41, because you take a good history, and she's got a sister that has tendinous xanthoma. So she meets the Simon-Broom criteria for heterozygote hypercholesterolemia. She's got an LDL that needs treatment. Perhaps you can get the insurance company to pay for one of the 2 drugs that's FDA approved. And I think currently you're more likely to get it approved for the second patient than for the first patient. But time will tell who will pay for these drugs. So these are monoclonal antibodies that are very promising and potentially may be the most effective approach to reducing LDL. When added to diet or statins, ezetimibe and LDL apheresis, they're beneficial. When patients cannot tolerate a statin, they've been shown to be beneficial to also reduce Lp(a) and triglycerides. They have a very favorable side effect profile, but we don't have outcomes, and we're anxiously awaiting the outcomes. So, in summary, you should recognize the 4 patient populations who benefit most from statin-based therapy. You should recognize the controversy in LDL targets versus intensity of statin. You can define the population where additional lipid-lowering agents, with or without a background of statin therapy, have further improved cardiovascular outcomes. And you can define the role of the PCSK9 inhibitors to further lower LDL cholesterol, anxiously awaiting the cardiovascular outcome studies and paying close attention to who will pay for these drugs. So, you did well before. How confident would you be in treating your patients with hypercholesterolemia? Please answer now. We'll take a couple of questions, and then we'll turn it over to Dr. Urban to close out the morning. Look at that. Now, there are more people. Come on. You're all that confident? Okay, questions. There was one question earlier. What was it? Yes?
Any role for LDL particle?
Okay, LDL particle.
Are we following the wrong part?
I have never ordered an LDL particle number in my practice, but I practiced at the VA for 32 years. Now I'm back at the medical center, and my lipid colleagues, they do like to get particle number. I don't know what to do with particle number. I think non-HDL is just as good, and it doesn't cost any money. So until I see an evidence-based trial that targets LDL particle number, I'm going to continue to do what I'm doing. That's my approach. I don't think you're wrong if you want to get particle number. I just hope you can tell the patient who may be charged for the lab the evidence base of why you're using particle number. I don't have any. Any other questions? One last one. Jack?
I got 2 patients. These are real patients. 60-year-old
Okay, that's an excellent question. First, let me talk about calcium scanning or calcium scoring. First of all, I think it's a good tool for risk stratification, and it should be used for deciding if a patient is a candidate for a statin. So when you're on the fence of a patient, of not being clear if they should or should not be on a statin, I think a coronary calcium score can be helpful. If it's 0, you should not put them on a statin. If it's anything other than 0, I think you probably should put them on a statin. But if it's 900, I'd feel very comfortable putting them on a statin. However, I am not in favor of vans going around the cities of our country doing all these non-invasive tests with carotid intermediate thickness or coronary calcium unless there's a true reason for doing it. I think these technologies need to be used in a focused way when you have a particular question you're asking. And in your case, Jack, you were asking a good question. Should I use a statin? 0, no. 900, yes. And that's what I would document in the chart.